On to the next scientific session. Let me welcome Dr. Pamela Christudoss. She is the professor and head of biochemistry at CMC Vellore, and she is very well known to everybody. She runs the largest EQA program, which covers more than 10,000 labs in India, which is the CMC Vellore biochemistry program. She's been professor and head. She's been head of biochemistry. She's been actively involved in teaching, and she has a huge number of publications. And with her is Dr. Krishnajyoti. Oh, he is the most multifaceted personality I've ever met. My dear friend Krishnajyoti, he is always in two places at one time. He is one in biochemistry in Lincoln University in Malaysia, and he's the head of a hospital in Calcutta, number one. Apart from being a fantastic biochemist, he's an hospital administrator and has a degree in law. I mean, he doesn't leave any stone unturned, no corner left. And amazing amount of scientific papers. He's been the president of Association of Clinical Biochemists of India. If you have a multifaceted personality who's going to make you enjoy this meeting, is Dr. Krishnajyoti Goswami. Welcome, and please take over this conference. And welcome, Dr. Tester, please.
Thank you very much. Thank you, Dr. Alok, for your kind introduction, and good afternoon to all the panelists, the committee, the KO committee, the organizers, and as well the participants. I have the privilege and the honor to introduce our eminent speaker for the next topic on quality indicators in medical testing labs, a very hot topic indeed. Dr. Ashavaid, I would like to introduce her to you. Dr. Ashavaid is the consultant biochemist and chief of labs, director lab research of PD Ahuja National Hospital and Medical Research Center. A PhD topic was on cardiac biochemistry. She has a number of fellowships and vast experience in research. She's a fellow of the National Academy of Clinical Biochemistry in USA and National Association of Clinical Biochemists of India. She was awarded the status of Chartered Scientist by the Science Council of UK, the chairman of ISO committee of the hospital. She was a driving force for establishing many new lab facilities in the hospital, which was first in India: the therapeutic drug monitoring facilities, toxicology department. She established Ahuja Hospital Drug and Poison Information Center, and she was qualified as CAP inspector, nominated as a CAP ambassador for India. She has a very vast research experience on preparation of sarcoplasmic reticulum vesicles from rabbit skeletal muscle. She has experience on ultra-speed preparative centrifuges, liquid scintillation and gamma counters, gel scanners, experience on fatty acid composition, on gas chromatographs, mass spectrograph, and very good experience on biochemical mitochondrial enzyme assays on sarcolemma preparation, demonstration of sodium and calcium exchanger in the vesicles, detection of beta and alpha adrenergic receptors in the sarcolemma vesicle, and of course, setting up a cardiac multi-locus macroarray. She has indeed a keen desire to determine gene variants associated with coronary artery disease in Indians using the cardio-metabo chip. I would now like to call upon Dr. Ashavaid. Over to you, ma'am. We look forward to your valuable information.
Thank you very much, Pamela, for a very long introduction. But let me first thank Dr. Seema Bhargava and the other organizers for inviting me for this talk. I also thank Dr. Lalitar and Dr. Krishna Goswami for being there and for co-chairing. And of course, you, Pamela, for chairing the session. So friends, without much ado, I'm going to talk to you about the quality indicators in medical testing laboratories. All of us are aware of the testing cycle, the total testing process, which happens outside the lab as well as inside the lab. The first decision is of the clinician to perform the test, and then the order for the test is placed, order is transferred to the lab, identify information that is entered. Specimen is obtained either by phlebotomy or the nurse draws it and sends it over and comes within the walls of the laboratory where the specimen is analyzed. In the laboratory, the report is generated. The result is conveyed to the clinician. It is interpreted by the clinician. And according to that, there is a clinical response which is elicited in the patients. Thus, you see, it is a very complex cycle where it involves the lab and it also does not involve the lab. And all these arrows that you see are the points where things can go wrong. And therefore, each of this needs to be quality controlled. Quality systems in our medical laboratories are inspected by accreditation bodies, may it be NABL, may it be CAP, it could be CPA, it could be RCPath, whatever. And most of them use ISO standards. And these standards, if you go to see, are based around the operational aspect of our analysis. Of course, you have the management aspect and the technical aspect. But very few look at the clinical quality or the appropriateness of service and the outcome. There is some debate right now in the accreditation committees about focusing on measuring the quality outcomes in the labs. The labs are good at incident investigations, as we know. We do a lot of surveys on the patient feedback, patient waiting times, physician satisfaction. But we are truly poor at clinical guidelines, studying test utilization, assessing test interpretations by physicians, etc. And in fairness, we spend more time on our internal activities within the lab and not enough time on the external healthcare activities. I'm sure all agree. But those also need to be measured effectively. And therefore, we need quality indicators. But before we go on to that, what are quality indicators? Quality indicators, as defined by the Institute of Medicine, Washington, is an objective measure of looking at or evaluating the healthcare domains, which could be patient safety, patient effectiveness, patient-centeredness, timeliness, and efficiency. Note the word patient all the time. By doing this, the risk of error is minimized by the quality indicators, which could be used as laboratory improvement strategy and could be used for monitoring and improvement. What is the purpose? The purpose is to keep error risk at low levels. And how would the staff understand what we are saying? They should know what is to be measured. They should know the performance standard that is expected of them, the entire total testing process which is involved in it, and what point comes before the points that they are investigating, the way in which the events under the control have to be measured, and what could the problems be in those measurements, the information that is to be transferred, and they also have to decide on which individual is going to collect, who's going to analyze the data, who will take care of the corrective actions. How frequently is the data to be collected, the way in which the data will be analyzed, and how would it be required for evaluating the quality improvement. Quite a tall order, if you ask me. Now, if you look through this testing cycle, you'll find that in each of these steps, there is a time lapse. For example, there is time lapse in lab testing. Once it comes to us, there is time lapse. Physician action takes some time. Patient outcomes also take some time. If it is pre-analytical, the clinician, the nurse, the patient, those involved in patient identification, all of them, there is a lot of time that is lapsed. Data entry, specimen collection, and transport, of course, takes the highest priority. Coming to analytical phase, it's a well-controlled thing. So when it comes to the laboratory, we try to control it, and we try to control it to the best of our abilities. Post-analytical, we need to await a response to the lab report, that is from the clinicians, their interpretation and utilization. It is the physician who's going to make clinical decisions. But unfortunately, clinical decisions, when the physician makes, he cannot perceive the lab errors. What happens is, he is not aware of the pre and the post-analytical processes in the lab. And therefore, he sometimes does not know how harmful it can be. And on our part, we are fairly reluctant to divulge the data of the frequency and the types of the errors that we have committed, because we are scared of the blame. We are scared of our individual failure, our false pride, and culpability, which is associated with this event. So let us quickly go through the quality indicators. We, as all of us know, and all of us practice, we have the pre-analytical phase, analytical phase, and the post-analytical phase. And let us quickly understand what it is that we generally do. Now, this is the data from my lab, and these are the quality assurance program. We have about 126 quality indicators, analytical being the bulk of it, as we have various sections. Then it forms about 68%. Post-analytical is about 17%, and the pre-analytical is about 15%. What do we understand by pre-analytical quality indicators? Well, all of this. As I told you earlier, we are good at surveys. So we can do the OPD patient waiting time, patient feedbacks, indoor patients, consultants, how they evaluate our lab, how do they look at it, what is their feedback, time of specimen collection for urine routine specimen, and culture sample transport time, and of course, this wristband verification. Now, a small anecdote on wristband verification. When we started the hospital sometime in '87, it was from day one that we put the wristband on all patients. In one of our quality indicators, we saw that we were doing a number of repeats, quite a few repeats, and the results were not exactly matching. And we were wondering how this could be. We looked further and we found that about 40% were not wearing the wristband. And the nurses vouched that they were putting the wristband. This had become more intriguing. So we looked further, and what we found is that those patients were the ones who were sent for surgery. Now, in surgery, the anesthetist would snip off the wristband because they wanted an access for the IV lines. Thus, the wristbands were missing. So we included that as one of our wristband parameters, indicators, to see how often this happened. We put a number of things in place. In fact, the entire protocol, thanks to our quality officer. And we looked at, lab implemented this revised policy, put in this protocol to verify the wristband. In case the patient is without it, he would contact the nursing floor, document and take acknowledgement from the nursing staff, who at that point was a little reluctant to acknowledge that there was no wristband. They would identify the patient. We'd go ahead with the specimen collection, and this set of information would go to the quality cell, who would then liaise with the nursing manager. But over a period of time, we really improved. So this has been a worthwhile indicator to pursue. The next one was the waiting time in minutes of OPD patients of the lab services. Now, there have been times we generally do not like the patient to wait for more than 10 minutes, and we try to do it as well as possible. This is, of course, system tracked. But there have been times when we have had a spike in the process, as you can see. And of course, the line indicates that this is the benchmark. And we then trace this further to find that this is a new phlebotomist who has been inducted. And then, of course, training and counseling and all, who takes care of that. Some of the other parameters that are there are the urine culture, the blood culture turnaround times, the molecular sample adequacy, etc. Coming to the analytical, the one that we all love. It's common to all. Turnaround time of tests, I think all sections do. Critical value reporting for routine tests, routine specials, and the special tests, which means those tests which are not done by anybody in the country or in the city. It could be either. We make it a special point to call up the doctors and give them the results because these are such special tests. Of course, reducing wastage is one of the things. LIS equipment breakdown and unacceptable proficiency testing. This goes on without say. The very heart of the analytical part is the quality control. Internal quality control, without which no result goes out of the hospital, done absolutely on time. And the external quality control proficiency testing, where it could be proficiency testing, it could be graded, it could be ungraded, number of PTS, and interlab comparisons. All this forms the heart of the analytical soul. So you see, the analytical time, rights and sentiments time, has really come down. And I'm sure it would be in your labs too. All labs, we like to perfect it because we have a sense of pride. And if you were to look at it now, look at analytical, where it stands, and a glimpse of what the analytical parameters would be. In biochemistry, we have something like trend analysis, CV monitoring, evaluating the sigma metrics, LIS downtime, critical reporting. For example, we did trend analysis. It is a thing that has been initiated actually by my colleagues. And we did notice in one of the analytes, that is calcium, we had established the mean, our own lab mean of 7.8 with n equal to 20, which is what the protocol suggests, and this being the lab range. We found that this is what the mean was, and this went out, and it's above beyond 2 standard deviations. We did all the troubleshooting we could. We accumulated a lot of points. A lot of data points, sorry. And with all this, and then when we looked at the peer mean also, the peer mean also had shifted to 7.6. So that gave an indication that we should also move. And this is what we got on a cumulative mean also when we added more data points. So we moved it, as you can see over here, and things became much better and the analyte became well controlled. It thus saved us unnecessary troubleshooting, and reruns of QC were remarkably reduced. Sigma matrix we did for calcium, as you can see, just fairly good, and it's also very finicky, as all of us know. The maintenance protocol, when we saw it going down, we revived the maintenance protocol rather early because our instrument was aging, and so we saw that, it required more often, it required the maintenance more often. And as far as protein is concerned, there was a defect in the magnetic stirrer. And all of us know that it takes only 3 microliters of the serum to be put into the reagent, which is very little for the magnetic stirrer. And this had caused problems, which became okay when both the things, the magnetic stirrer and the syringe were replaced. Coming to blood bank turnaround times, there are quite a few. Blood collection inadequacy, completeness of register master. Now, this is something which is local, because when you faced or I face a problem, we would like to make this as an indicator because that can be monitored. So these are local things which depend. Elective surgeries, whether how many of them were elective, and I'm sure all blood banks have this problems, RBC wasted, expiry, transfusion index, cross-match, etc. And this is one of the key indicators from the blood bank, where they've looked at cross-match to transfusion ratio, and where a benchmark is of 2.5. Often this has gone down, often this has gone above also, and these matters are taken up by the transfusion committee. The head of the blood bank notifies the transfusion committee, who then looks into it. Coming to hematology turnaround time, the bone marrow biopsy reporting, all these turnaround times of all these are looked at. And here is lupus anticoagulant reporting on time, 100% all the time. A thing of caution to be added is when you get it 100% very many times, it is time to change, because you can't get better than that. And therefore, one must change this quality indicator. Histopathology has its own set of quality indicators, reporting demographic, breast predictive markers, small specimens. Once again, billing compliance, and one of the issues that we had, reporting of critical levels of routine tests, labeling compliance, etc. And if we look at one of this that they had was the reporting of the small specimens, the benchmark of which is to report it in 96 hours. And if it did not, then here are a set of reasons why it would not. For example, if one was overshot, then it was delayed because of a special stain, so on and so forth. Microbiology turnaround time, you have blood cultures and urine cultures, turnaround time for our friend expert, critical reporting, positive findings of biofire by 100%, these have to be communicated to clinicians so that they can start the therapy as soon as possible. And findings of the viral markers and positive TB cultures, again, another thing which should not be missed out, as TB culture takes about 6 weeks to grow. So these should be communicated without fail to the clinicians as well. This is the clinical reporting in microbiology. For the routine blood cultures, we found that at the night time, when the culture rings positive, then that is generally from 7 p.m. to 9 a.m., there's only one person, and that person may, out of more work or other activities, would not report. So this was started out as an indicator, and we achieved quite a bit of success in that. Coming to the post-analytical inequality indicators, we of course have equipment downtime status, data transmission, and plant maintenance, which I'll show in a minute. Equipment preventive maintenance performance, which is monitored and initiated both by the quality cell. And not only that, we also get an alert. The maintenance department gets an alert to say that this is now impending. There are various other things of routine test reporting, induction, training, which form an integral part of the lab. And by all means, we have competency assessment for the entire technical staff every year, twice a year in our department. Safety not to be left out. We have the chemical safety in the lab, radiation safety, because we do have a little bit of RIA, needle stick injury, noise safety levels not to exceed 76 decibels, the fire safety with its drills, routine drills, well scheduled. So friends, we really have traveled a very long way. As you can see, right from top to today, we are somewhere over here. But after this, what? We can incorporate more. And what can we do? IFCC working group on lab errors and patient safety establish a series of indicators which is designed for the clinical labs. They identify 27 quality indicators, out of which 20 that were picked up were not at all related to the laboratory environment, to the internal environment or the laboratory. They were related to the interface of lab and the clinical part of this. So as you see, the model of quality indicators, which was developed by this group in the year 2016, added 53 measurements. So one would have to measure 53 elements in this, and they set up a priority index score, which has been assigned to every quality indicator. Just to highlight the importance of the individual QI. So we have the order of priority as 1, which is mandatory, 2, which is important, 3, which is suggested, and 4, which is value. And if you look at this matrix, this is what it looks like. On the left side, we have all the various phases. And on the top, we have the priority 1, priority 2, priority 3, and priority 4. Of course, these are the key quality indicators. This does not mean these are all the quality indicators. And if you have an appetite for more, by all means, access this site, and I'm sure you will not be unhappy. So now error stratification, if you see, we have 14% in the pre-analytical, 7 in the post-analytical, which can be further stratified as the pre-analytical and the post-analytical quality indicators. Now, what is it that we have in the pre-analytical phase? It involves selecting, ordering, appropriate tests, collecting, identifying, labeling, handling, all this. These processes, as we know, are not performed by us and they are not under our control. That is why we continue to get a lot of problems. It is that the clerical staff or the nurses in the wards do this, but they are not to be blamed because they have many things to do. This is just one of them. In fact, we noticed in a previous study that we did some time ago, when we did the specimen collection study, we found that the specimens that were collected in the wards by the nurses or the junior medical staff were more prone to errors than those that were collected by the phlebotomists. So, and the post-analytical phase covers the poor communication between the laboratory professionals and clinicians. Please do not be shy to talk to your clinicians. They are our friends. Notification of abnormal tests, even discussing with them is always very good for reports and interpretative comments. We do have some very bright clinicians who come up to the lab and have regular meetings with our consultants in the laboratory. Now that is what is required and is to be encouraged more and more, because then the misunderstanding by the treating physician also gets cleared and the significance of the information becomes more apparent. Interpretative comments should not be silly and trivial. They should be something which would help the clinician interpret the complex data. Certainly, the data which comes from NGS and all those platforms, they definitely need help, and so do many others who are also in the field. Please remember, clinicians are interested in the quality of service. Quality of the service, which means that you would give no test which would be imprecise and which would not be true. They require that it be available, the cost is known, the relevance is there, and timeliness is also maintained. If a test is not available on time, it doesn't make any sense. Before I end, I switch gears and take you through an interesting aspect which I had a look at. I looked at the lab testing errors which lead to medical malpractice claims. So one insurer here, I've given the site, the malpractice payouts in 2017 reported that 34% of the medical malpractice payouts result from diagnostic error. Another insurer reported 52% of the medical malpractice claims, which were error in diagnostic or lab testing processes. And a study which is made by somewhere in Boston and in Ann Arbor in Michigan, what they did is they carried it out in inpatient setting. These were the people who put the malpractice claims, and they took that, the source of this is the US National Practitioner Database. A multivariate logistic regression was done to find out the paid claims. The paid claims were the highest amongst the surgery group, and the second highest was diagnosis-related paid claims, 32% out of 109,000. And 50% of the 32% were really due to failure of diagnosis, delay in diagnosis, or wrong diagnosis. And I'm sure you'll agree that the incidence and economic burden in this is substantial, which was shown as the outcome of the study. So now, what is it that we should do? Well, we sharpen our claws, so to say, and move in and have more clinical indicators and monitor those aspects where there are gaps. Many of these indicators are related to good clinical governance and need the labs to carry out clinical audits. We shy away from them. Whilst clinical audits have been recommended as a part of the quality system, even in developing countries, there is no process where it's being carried out. And in recognizing that the quality improvement, some countries have gone far ahead. They have a quality audit committee and which is linked to the quality assurance division. So there is a feedback mechanism. We need to write guidelines to assist the laboratory personnel to carry out these clinical audits. And of course, this is with the clinical counterparts. So the key message that I leave everybody with, after looking at the TTP cycle, we all agree on certain points. Laboratory is not just sending the sample and coming back with a result. It is a complex system, and all, I repeat, all must function properly in order to achieve quality. We should implement it, and of course, implementation will vary with the local situation because it varies from one to the other. How do we start it? Which is start at the beginning, the very beginning. The one which is easiest to implement and do it in a stepwise process. All quality management system elements must be covered. We cannot do one or just specimen obtained. We can't do that. We should complete the entire cycle and therefore have clinical audits and benchmark your performance against the best labs in the world. Thank you.
Thank you, Dr. Ashavaid, for that very highly informative and enlightening lecture emphasizing on quality indicators in medical laboratory. Yes, indeed, quality indicators in the lab is very much required. It could be time consuming, but is very much challenging as well. I'm sure we all agree that QIs will be needed and will have an important role to play in improving lab performances. From our experience at CMC, we have seen that we have steadily improved using most of these quality indicators, whether it is TAT, pre-analytical, analytical, or post-analytical. And I would like to say that improvement definitely comes along with continuous or frequent training of the staff. Over to my co-chairperson, Dr. Krishnajyoti, for questions or any comments. Sir, over to you.
Thank you, madam. Thank you, Dr. Ashavaid, for your nice presentation. It's a wonderful presentation. It's like 1990 onwards, you are giving the master stroke in the clinical audit, in laboratory audit, and laboratory quality assurance program. It's a fantastic presentation.
My question is regarding the quality tools and audit of POCT devices. Like when I read about your profile, like I'm from IFCC scientific division, and so you have done like, enormous work on POCT. So when we plan for internal audits for POC devices, we find the challenges during the audit. So what quality tools, quality indicators, or audit plan and processes we can for the POC devices in hospital settings. Quality indicator, Dr. Ashavaid, ma'am, if you can suggest for us to take up.
I really haven't devised any quality indicator for the POCT. We use very less of POCT because our clinicians actually do not advocate that, and because it moves out of the confines of the laboratory, it is difficult to monitor. But ideally, what one should be doing is to check the quality, like if you have glucose analyzers. And when I was in UK, what we did is we got all the analyzers back, of course, in a scheduled manner. We checked it with the laboratory readings, and we also checked with the quality control. And there was a regular schedule that was drawn up. So something like that would have to be devised, because these can go notoriously bad and you would not know it. And it comes, we have had instances where the clinicians have come fighting to us that their POCT is right and we are wrong. So, and we have corrected that. So I'm sure that's your experience also. But really, now you've given me some food for thought, and maybe next time I can answer your question better.
Thank you, ma'am. Before
you close the session, Dr. Pamela, may I make a comment?
Yes, please.
Beautiful presentations. Dr. Ashavaid, I think what I like best about your takeaway message is that once you find that you're doing very good in one quality indicator, it's time to stop looking at it and go on to the next one.
Of course, we are not gaining anything.
That is so practical. Otherwise, we like to believe, oh, but we are doing good and we are fine and we don't really need to do anything else.
I would like to thank Dr. Ashavaid for the wonderful presentations once again. Thanks to my co-chairperson, Dr. Krishnajyoti. Thank you, Dr. Seema, and the KHO team for giving me this opportunity to be a part of this panel.
Thank you, chairpersons, Dr. Pamela, Dr. Krishnajyoti, for holding together a very invigorating deliberation session. Your comments and those fantastic inputs have made this last 1 hour, 1.5 hours most interesting.